Good afternoon. It's 5 minutes past noon, and we'll begin our today's presentation on addressing tobacco use and exposure in mothers and children. And I want to thank you ahead of time to those of you who contributed to our survey that we sent out a couple of weeks ago, asking for some of the challenges that you are encountering when you are working with your families, and what questions you've had come across this topic with in your work. So I appreciate those who have sent those scenarios and comments to us. So today we have Dr. Deborah Ossip to present on this topic, and throughout the presentation, I encourage you to send those questions or send comments as she is presenting. You can send your comments to everyone, or you can send it privately to Pam Whitcomb.
Nope, Maternal and Infant Health Center of Excellence.
Thank you. And then we will manage those as we go through the webinar today. All right. At this time, thank you, and I will hand it over to Debbie.
Great, thank you very much. So hopefully everyone can hear me, and if not, please do comment in. And I'd like to echo the thanks for sending in your comments, and there were some particular challenges that people have raised that we'll actually be incorporating in as scenarios later in the presentation today. As Raquel said, we'll be talking about addressing tobacco use and exposure in mothers and children. And I want to point out that if you would like some additional training on this topic, this is a very nice link for a program that has been made available at no cost through CDC for additional training. And I encourage you to at least click on the link and take a look and see if it's something that you might like to pursue. This is what we'll talk about today. We'll look at the risks of maternal tobacco use, the risks of second and third-hand smoke. We'll look at other tobacco products, hookah, e-cigarettes, or vapes. And a question came in about smokeless, so I've added on a bit on smokeless tobacco use. We'll talk about implementing the triple screen for tobacco, as well as interventions associated with that screen. And then we'll talk about integrating interventions into your practice. We'll be doing some videos. I'll be looking at your comments as they're coming in. As questions come in, some I may address when they come in, some I may hold until later. But please do send those in, and then we'll also have sections for you to comment on, and we'll be doing some case scenarios later in the presentation. Here are the data. This is what the stats look like, and this is for New York State. About 16.5% report smoking before pregnancy, about 6.4% report smoking during pregnancy, 11.4% after delivery. And so if we look at like the rates during pregnancy, this is below the national average, probably due to the pretty intensive tobacco intervention programs through the Bureau of Tobacco Control and other groups in New York State. But if we look at what the data look like outside of New York City, you can see the rates go higher. And so you can see for each of those categories. And actually, when we look at smoking during pregnancy outside of New York City, when we get to the upstate area, the rates are actually a little bit above the national average. We know that relapse rates following smoking cessation during pregnancy are quite high. And I want to make the point that pregnancy is kind of an interesting time period in that even if the woman only stops smoking during pregnancy and then relapses afterwards, there's still benefits to the child. So if you have your patients or clients who have stopped during pregnancy and then they're relapsing, you have already conferred by working with them a benefit to their child because they've quit smoking and have kept the child from exposure to tobacco toxicants during the pregnancy itself. However, we of course would like for women to not smoke at all, to certainly not smoke when they're trying to get pregnant, to not smoke at all during pregnancy, and to not smoke after pregnancy, to not relapse. And what we know is that the relapse rates are high, and no doubt you've seen that with your clients as well. And you can see the rates for New York as a whole and a little bit above are the rates for New York City, just dancing around that national average. So about half will relapse in the postpartum period, and by 6 months, about 70% of those who have quit have relapsed. There are disparities in use during pregnancy, and so if you look at pregnancy by race ethnicity, rates are lower in non-Hispanic other populations and in Hispanics. If you go down one block, New York, smoking in pregnancy by age, use rates are higher in the younger age groups, teen pregnancy, 20 to 24-year-olds. We see that education gradient, smoking rates are lower in those with more education, and much higher among those who are economically disadvantaged. In this case, the marker is Medicaid. And when I say most of the data that have been available on smoking, so I'm presenting those data to you, but these are very robust findings that apply to really pretty much all forms of tobacco use. There is no safe level of tobacco use during pregnancy, and we will be addressing some of the other forms of tobacco use. Okay, so why do we worry about this? What are the risks for women who smoke? These are the most common risks that most people are aware of that apply to anyone who smokes or uses tobacco: cardiovascular disease, cancer, respiratory diseases. These are some of the less common known risks of smoking and tobacco use. Increased risk for osteoporosis differentially affects women. A compromised immune system. So, for example, we'll see decreased wound healing following surgeries for people who use tobacco. And particularly for women who are pregnant, certainly you don't want them to have a compromised immune system during or after pregnancy. And if you think of the case like if they're going through a C-section, they are likely to have delayed wound healing if they are tobacco users. And this might be a discussion point for you if you have a woman who's trying kind of on the fence or needs another motivator to quit smoking. That whatever wounds are incurred through the pregnancy or the delivery process, particularly if she needs a C-section, this gives her the best chance of healing if she quits smoking. And thrombosis or blood clots with oral contraceptives. There are specific reproductive health problems: infertility, conception delay, pregnancy complications, menstrual irregularity, and earlier menopause. And earlier menopause puts the woman at risk for other kinds of diseases that from which she's more protected prior to menopause, so things like cardiovascular disease. So the earlier menopause is putting her at risk for other kinds of diseases that would otherwise not be occurring at that stage of her life. And if we look back at the pregnancy, this is the laundry list of at least some number of the effects caused by tobacco use during pregnancy: increased risk of miscarriage, fetal death, preterm delivery, low birth weight baby, ectopic pregnancy, and you can see the list as we go down. And a couple that you may not be as familiar with are the link between tobacco use during pregnancy and neurologic changes that can result in behavior problems in children, including hyperactivity, attention deficit disorders, and other kinds of behavior problems, cognitive deficits, learning disabilities. And smoking and probably tobacco use, although the work that's been done has been done with smoking, predisposes the fetus to later obesity. And it's possible that this operates through the mechanism of causing lower birth weight at delivery, that there's kind of a catch-up function that predisposes the infant to later obesity, or it may be an independent mechanism. So what we're left with is that smoking and really tobacco use in general is the most modifiable risk factor for poor birth outcomes. There are many bad things that can happen during and after pregnancy over which the woman may have limited or no control, but this is something over which there is control, and that's related to tobacco use. So the American Academy of Pediatrics several years ago really issued an urgent call for action to address tobacco use in pregnancy to give the greatest improvement in birth outcomes for populations who smoke, use tobacco, or exposed. And the health effects of maternal tobacco use really extend across the lifespan. So if you look at the blue on the lower left, in utero, we have the low birth weight, stillbirth, and neurologic problems that we talked about. In infancy, sudden infant death syndrome, bronchiolitis, inflammation of the airways, meningitis. In childhood, increased risk of asthma, middle ear infections, fire-related injuries. In adolescence, kids who have parents who smoke or use tobacco are more likely to begin themselves, and then they begin the process of nicotine addiction that spirals them downward into generally long-term use and puts them at risk for cancer, cardiovascular disease, chronic obstructive pulmonary disease, respiratory disease, and the whole laundry list, and then they perpetuate that cycle of tobacco use in pregnancy. So this is really an important time to address it and to see, can we break that cycle? And I've added on obesity as kind of a more, maybe a more recently identified risk of tobacco use during pregnancy, predisposing the child to later obesity. Okay, so let's talk a little bit about what your clients know about the risks of smoking in pregnancy. And we're going to do the first poll. This is a list of, we'll have 2 slides of a list of some of the myths that have been culled on one of the government sites that have been identified during pregnancy, myths that may be present about tobacco use. We've heard some of these here with our populations. And so the first poll is, how many of you have heard at least one of these myths among your clients? And go ahead, does everyone know what to do with the poll?
Yep, go ahead and select your option and make sure to hit select after you choose.
Okay, and can we post the results? Or
yep.
Okay.
Yep, so once we're, let's see, so we're at about 23 people have voted, so we'll go ahead and give you a second, and then we're going to close out this poll. All right, and here are the poll results for you. There's the results.
Okay, so, and can everyone see those results right now? Okay, fantastic. I'm looking at a different screen from what you are, so I want to make sure that you can see. So virtually everyone has heard at least one of these myths, and this is distressing, but they're fairly common myths. So let's go through each one, and we're going to flip back to the screen. Okay?
Yep.
And so the first one, I smoked during my last pregnancy and had a healthy baby, so this baby would be helpful too, you know, everything's fine. And in fact, the fact is, every time you smoke during pregnancy, you put your baby's health at risk. If you smoked and had a healthy pregnancy in the past, this does not mean your next one will be healthy too. You're really playing with fire. This is like Russian roulette. You got lucky last time. Why take the chance this time? Myth number 2, there is nothing wrong with having a small baby. And indeed, we've heard here in some subgroups, people say, well, it's actually a good thing to smoke or to use tobacco during pregnancy because I want a smaller baby. It's going to be an easier delivery if I have a smaller baby. And this is very serious. This is very concerning. And in fact, low birth weight babies are more likely to have serious health problems than normal weight babies. The way this baby gets small is not a healthy way for that to occur. It's from exposure to toxicants that prevent the kind of normal growth that we want the baby to have. And these problems can affect your baby's health as a toddler or as an adult, as well as during infancy. And smoking during pregnancy, and in fact, tobacco use during pregnancy, increases the chances of having a low birth weight baby. And this is robust across all forms of tobacco use. Okay, I'm 3 months pregnant. There's no point in stopping now. The damage is done. It's too late to quit, that kind of a messaging. And in fact, there are benefits to quitting smoking at any stage of your pregnancy. We, of course, want women to stop using tobacco and stop being exposed to tobacco as early as possible, but it is never too late. So if you quit now, here are some things. Your risk of having a low birth weight baby will be similar to that of a non-smoker, and quitting now also increases the chances that your baby's lungs will work better. Okay, and finally, smoking relaxes me, and being relaxed is better for me and my baby. And in fact, kind of in the old days, before we had the kind of research we have now, obstetricians would actually sometimes say to women, you know, what you're going through with withdrawal is actually worse for your baby than if you were to keep smoking and be more relaxed during your pregnancy. And that is absolutely wrong. It's a myth. So you may feel calmer when you're smoking, but the results inside your body are quite the opposite. Your body is acting as if it is quite stressed. Higher heart rate, increases in blood pressure. Every puff of a cigarette also increases the carbon monoxide in your bloodstream, the same as if you were sucking on a car's tailpipe. And the more carbon monoxide you have, the less oxygen is getting through to your baby. And that happens with every single puff that you're taking of a cigarette or every single tobacco exposure that you're getting. Okay, let's do the second poll. Take a look at these myths and how many of you, go ahead and respond, how many of you have heard of at least one of these myths? Okay, and we're setting that up here.
There we go.
Okay, so go ahead and respond. And we're still going, we're still getting responses, and also, again, a very high, so far, very high yes rate, although somewhat fewer on this one, but still, we're still at well over 80% on this.
That's good.
Okay.
And here's the results.
So 83% of you have heard at least one of these myths among your clients. So let's take a look at these myths. And we're switching back over. So quitting smoking will be too stressful on my baby. You know, again, that same side, well, it's more relaxing to me if I smoke, and that's better for my baby. But here, quitting will be too stressful. So let's take a look at, so continuing to smoke harms your baby. Quitting does not put extra stress on your baby. It's one of the best things you can do for your baby's health. And you can read this, but in terms of the actual risks that you're protecting for the infant, you'll be protecting your infant from the dangers of secondhand smoke and reducing the risk of sudden infant death syndrome when the baby is actually born. Okay? Smoking fewer cigarettes during pregnancy is good enough. And one of the vignettes that we'll be looking at later on that someone had sent in is someone who said, well, you know, I've done a great job. I've put back on my smoking, which is great. And that's a great start and deserves to be really supported. But it is not enough. There's no safe level of tobacco exposure during pregnancy. So it's not good enough. It's a good start, and it's an excellent start, but there's no safe level of smoking. Even a few cigarettes a day means harmful chemicals will reach your baby, damage your health. It's never too late to quit. And you can read this, and I'm not sure how many of you have seen the New York State campaign, the every cigarette does you damage, that every puff you take, you're inhaling toxicants, and it's the same for your baby. Every puff you take, you're inhaling toxicants that are getting passed through to your baby. So even one cigarette a day, even 2 cigarettes a day, it's great if you reduce, but it's not enough. It's got to be at 0 to give your baby the maximal benefit and to prevent those controllable toxicants, the things that you have control over, from getting through to your developing baby. And then finally, if I stop smoking, then I'll gain too much weight. We hear that a lot. I'm sure you hear that a lot, which is actually pregnancy might be a great time to quit smoking. And it may be that, you know, it may be some messaging that as OBs have gotten better and kind of national guidelines have come out about how much weight you should gain during pregnancy and concerns about gaining too much weight during pregnancy, and that might lead to later obesity, that messaging might be getting through so that it's possible that that's raising concerns about quitting smoking during pregnancy. You might gain too much weight during pregnancy. But in fact, since weight gain is normal during pregnancy and tobacco exposure is so toxic, you can actually do some very nice messaging around that you're already going to be gaining weight. Think about the weight that you gain. We can talk about how you can do it in a nutritionally appropriate kind of way within the realities of your lifestyle. But, you know, what a better time to quit smoking when you're actually supposed to be gaining weight. And then we'll worry about it later on. And also the nutrients that you're taking in will get through to your baby more readily if you're not also putting tobacco on board. Okay, so what about smoking and breastfeeding? This is another question that comes up. We know that women who smoke, the data show, are much less likely to breastfeed. And actually, there's some evidence that smoking may make it more difficult to breastfeed. It may impair the milk supply. So it actually not smoking, not using tobacco in any form, actually increases the likelihood that the woman can successfully breastfeed. But in fact, women who smoke are less likely to breastfeed. The American Academy of Pediatrics, some numbers of years ago, reviewed the evidence and came out with their policy statement that breastfeeding is not contraindicated for mothers who smoke, that the benefits of breastfeeding far exceed the risks of smoking or tobacco exposure. Although women should certainly be encouraged to quit. That is the most protective behavior for the baby. Certainly, while women are breastfeeding, they shouldn't be smoking or using tobacco while they actually have the baby to the breast, because then they're getting secondhand exposure, and also they're getting, if they're using a smokeless form, they're getting the toxicants through their system pretty quickly while they're breastfeeding. They should wait to smoke or use tobacco until after they finish that breastfeeding session, and they should go outside away from windows and doors to not expose their baby to secondhand smoke. Okay, so let's talk a little bit about secondhand smoke. We've talked about the risks of smoking and tobacco use. Let's talk about the risks of secondhand smoke from any source of tobacco smoke, cigarettes, cigars, hookah, whatever the source is. And let's first define what secondhand smoke is. Firsthand smoke is what the smoker inhales into their lungs. Secondhand smoke is the mainstream exhaled by the smoker after it's been filtered through the smoker's lungs, plus the side stream smoke from the burning tip of the cigarette, cigar, and pipe. So it comes from those two sources. And we know that secondhand smoke, like firsthand smoke, contains thousands of chemicals, and this is part of the laundry list of what it contains, and several dozen known cancer-causing agents. And you can see, and I'm sorry, I think maybe this is a little bit blurry on the left side, from the last Surgeon General's report, to the kinds of things that we've gone over about what the health consequences are of secondhand smoke that are quite comparable to the effects of firsthand smoke. It's the same tobacco smoke. And the graphic shows what had been shown to be causally related to secondhand smoke at the time of the 2014 Surgeon General's report. And that list keeps growing. And as our research gets better and we're able to look at more factors, the things we look at generally have been found to be related to secondhand smoke exposure. So when we look at asthma, secondhand smoke can cause or exacerbate asthma. It can impair the effectiveness of asthma medications. It increases hospitalizations. It increases cavities. It increases cognitive deficits. You get poorer mental health outcomes with secondhand smoke exposure. For the infant, and secondhand smoke exposure for adults, again, a very similar list to what it is for direct smoking, and that list continues to increase. Part of the problem in having a longer list of causally related factors for secondhand smoke is that until we really had very good comprehensive tobacco-free or smoke-free regulations for clean indoor air spaces, everyone was exposed, so you had no control group for your studies. And now as we have more of these smoke-free spaces, we're getting less exposure, although, as we'll see in a minute, third-hand smoke is still a problem. When we look just at the asthma component, look at these figures. Children with parents who smoke are 21% more likely to have asthma than children of non-smoking parents. This is compelling, and this is preventable. I think that's the key message. You know, the bad news is, look at those figures. The good news is, this is preventable. Maternal smoking increases the odds of childhood wheezing before the age of 6 by about a third, by 31%. Again, compelling and preventable. Okay, we're going to look at a video and take a look at this video, and then we're going to do a poll. Is this an ad that you would want your client, that you think might be helpful for your clients to see? And I want to ask you this for a couple of reasons. One is that if you are bringing any mobile devices with you and have some things to show your clients, this is something you may be able to use. But also, one of the other hats that I wear is as the co-director of our Center for Tobacco-Free Finger Lakes, which is part of the Bureau of Tobacco Control's state-funded tobacco intervention centers around the state. So we can provide that feedback to the state. So your voice may be able to be heard in terms of what kind of messaging is making it into the media that your clients are likely to be seeing. Okay, so let's take a look at the video.
My son Aiden has asthma. Secondhand smoke has triggered his asthma so bad to the point where he had to end up in the emergency room. And he has spent multiple nights in intensive care. Now he's on a whole bunch of medications. My tip to you is, don't be shy to tell people not to smoke around your kids.
Okay, so this is from the CDC Tips campaign, and you may have seen, some of you may have seen these already, but let's go ahead and do the poll. Is this an ad that you would want your clients to see? And we're just setting up the poll right now. And after they do the poll, can they type in their comments on this ad? Okay, so please share your comments, and if it's something you want everyone to see, share that, because I'm curious about people's reactions.
Right.
Great, and I'm seeing a comment from someone about the myths 1 and 4 all the time. Let me pull the notes here to see which ones those were. Thank you for sharing that. All right, had a healthy pregnancy the first time, no problem now, and I feel more relaxed.
All right, and here are the poll results.
Okay, so this is an ad that people like, and again, please type in your comments on what kinds of things about that you think are effective. Okay, and I know very real way to depict what can occur. Yeah, it's very visceral, you know, when you see the child, I think, struggling to breathe and having to have the inhaler.
When you blow out tobacco smoke, over 4,000 dangerous...
Sorry, folks. Okay, we're going to see that in just a minute. Do not mask it, which parents or smokers may be used to. Right, yeah, that it's very real. And I also like the, you know, for me, one of the things that struck me is just the empowering nature of it. Don't be shy to say something. You know, it really is modeling, say something. Oh, that's interesting. Might be more powerful if this child spoke about how he feels too. That's actually lovely feedback. That would be pretty visceral too, about what it feels like to have an asthma attack that could have been prevented. Yeah, would connect the idea of quitting. Love it. Okay, thank you, everyone. Maybe we can compile at the end these comments,
Yep,
and I
absolutely.
will, you know, we'll circle back around and give this feedback. Thank you so much. Okay, so what do we know about secondhand smoke? Well, about 2 in 5 U.S. children are exposed to secondhand smoke in the U.S. About a third of teenagers are exposed to secondhand smoke in the U.S., and it's higher among some subgroups. Look at this. Among non-Hispanic Black children, nearly 70% of kids ages 3 to 11 are exposed. And what we know is that there is no risk-free level of exposure to secondhand smoke, just as there's no risk-free level of exposure to tobacco itself. And maybe a kind of a link or a hook for some of you, if you have people who have pets and are, you know, particularly indulgent and love their pets. So I've got a herd of pets at home. Pets are harmed by secondhand smoke as well. You can see cancers, and you can see the kinds of things that you see in humans, you also see in pets from secondhand smoke exposure. It's not only protecting their children, they're also protecting their pets by not smoking. So sometimes you may have a spouse or a partner who maybe doesn't believe about the risks of smoking for the pregnant woman, or think, well, I could just smoke when the woman's not home, but they may really love their dog. So that could be an interesting hook for them to not smoke, or to not smoke in the house around the animal. Okay, so let's go to the next slide. And so we've talked about direct smoking, we've talked about secondhand smoke, and now let's talk about thirdhand smoke. So one more poll. This may be the last one. I don't remember.
Yep,
I have another one.
this
This is our last poll. So how many of you have heard of thirdhand smoke? And we've got the responses loading. Are people seeing the responses as they're loading, or just at the end? Okay,
at the end.
So we've got about 27 votes in so far from 34. Okay, it looks like we've stabilized there. So about 2/3, close to 2/3 of you have actually heard of thirdhand smoke, which is terrific. It's a relatively new concept, and little by little over the years, more people are hearing about it. So let's talk about thirdhand smoke. Then we're going to get back to the slides. We're toggling back and forth here, so my apologies for the delays. You've probably seen this on other webinars too. Okay, so here's what thirdhand smoke is. So you see secondhand smoke, and then the question is, what happens when the secondhand smoke disappears? You don't see it anymore. Well, it doesn't really just disappear, it goes somewhere, and where it goes is it goes into the floorboards, and it goes into the walls, and it goes into the furniture, and it goes into the carpeting, and it goes into people's hair, and it goes into their clothes. And so thirdhand smoke is the contamination left behind in a room, in a vehicle, on clothing, hair, and skin, once the secondhand smoke is no longer visible. And here's what we worry about with thirdhand smoke. It remains chemically active. The stuff that's sitting there, it can get re-released into the air. And the chemicals in the thirdhand smoke can form new chemicals. They can combine with other chemicals that are just naturally in the air and form new chemicals that were not even in the secondhand smoke, including cancer-causing agents and tobacco-specific nitrosamines that were not in the secondhand smoke, but they do form in the thirdhand smoke as it ages over time. It lasts for weeks, months, possibly years. There's a landmark study that shows what happens when non-smokers move into an apartment where there had been smokers, and this is some months later. The apartment has been cleaned, it's been vacuumed, it's been painted. Non-smokers move in, and there are detectable levels of biochemically detectable levels of tobacco exposure in the adults and in the children who move now into this space that had previously been occupied by a smoker. And finally, we do not know how to get rid of thirdhand smoke. So we know it's there, we know it lasts a long time, and we don't know how to get rid of it. Okay, and so who's most vulnerable? Well, pregnant women are vulnerable, right, because they've got a growing child inside of them. And children are quite vulnerable. Why? Because they're crawling around on the floor. You know, if you think about like how kids get exposed to dust from lead, they inhale it. They do hand to mouth. It gets absorbed through their skin. It's the same thing with thirdhand smoke. So they're crawling around, they're climbing, they've got that hand-to-mouth ingestion. It gets absorbed through their skin, it gets inhaled. And because they're little, and because it's little, they're getting a higher dose of the same amount of thirdhand smoke than an adult would. And because they're still developing, the toxicants can get into them and can wreak the same kind of damage, likely, that secondhand smoke would do to them as well. So the research is new, and we're just starting to get some things coming out on what the exposures look like, and we don't know yet what the long-term health effects are. But since it's the same chemical composition as what you have in secondhand smoke, plus some new toxicants, we're anticipating that the news will not be good. So this is something for which we really want kids protected. And this really leads to the importance of having 100% smoke-free spaces, that places never have anyone smoking in them. And sometimes you'll see parents who are really trying to do the right thing, or partners, you know, they're trying to smoke like when no one's home, or they're smoking in a different room, or they're airing the house out, or they're airing the car out afterwards, because they're really trying to do the right thing. But in fact, what's happening is that the smoke stays there and it becomes thirdhand smoke, and the kids are still getting exposed. So we really are looking towards 100% smoke-free spaces. Okay, we know that the number one source of exposure to secondhand smoke and thirdhand smoke for children is in the home. And if you look at the middle two bars, what do we know about houses that have smoke-free rules? In New York State, with the orange bar, you can see that most homes that don't have smokers, in fact, have 100% smoke-free rules, or at least report that they have 100% smoke-free rules. But then look at the gray bar, the next to the last bar. Among New York State homes with smokers, only about a third have 100% smoke-free policies. These kids are getting a lot of exposure. Okay, and among a national trial that we've been doing out of Harvard, Jonathan Winikoff is a principal investigator on that, the CEASE study. Among smoking parents seen in pediatric practices, just over half report having strict smoke-free home policies. So these are smoking parents who are probably a little, they have more resources than perhaps the general population, because they're able to get their kids to pediatric practices for the regular checkups. And even there, only about half are reporting strict smoke-free home policies. Again, very disturbing, but also a real window of opportunity for intervention. Okay, and so what do we know about having strict smoke-free home policies? Well, one of the things that we found in the CEASE study is that parents who believe that thirdhand smoke is harmful are more likely to have strict smoke-free homes, controlling for a host of other factors. So this opens the opportunity again for conversation for you. If you can work with your clients around understanding thirdhand smoke, then you may find that your parents become more amenable and their partners become more amenable to keeping the places 100% smoke-free. We know that having a smoke-free home is associated with quitting smoking, in addition to the reductions in exposures to the kids. Parents, families who live in smoke-free homes are more likely to themselves quit smoking, even though the goal isn't to push them to quit, but in fact they do, and it's more easier for them to remain abstinent once they do. And kids who grew up in smoke-free homes are less likely to become smokers, even if their parents are still smoking. If you have a smoke-free home ban, kids are less likely to take it up themselves. And what about smoke-free cars, smoke-free vehicles? The news is even more dismal there, and the opportunities are again, quite large among smoke-free homes. So in the same national trial, among smoking parents, only about a quarter had a strictly enforced smoke-free car policy. Okay, and again, parents may be trying to do the right thing. They're not smoking when the kids are there. They're leaving the windows open. But you're getting the secondhand smoke exposure if they're doing it when the kids are there. And even if they're trying to not do it when the kids are there, you're getting the thirdhand smoke exposure when the kids come in the car where anyone has smoked. So the only way to completely protect infants and children from secondhand and thirdhand smoke is for all smokers in the family to quit. And the next best strategy, if they won't quit, is to institute 100% strict smoke-free home bans and smoke-free vehicle bans. Okay, so the kind of messaging, though, that we give to our parents or that they may be getting is really important to consider. And I'm going to show you a video, and then I'll ask for you to send in your comments what is good about the video and see if you can find what's wrong about this video. Okay, and can we keep the video available? Because I want to go back to the one part once we see the comments that come in. So send us your comments. What was good about the ad, and did you find the perhaps mismessaging in the ad? And I want to say this is out of Australia, and I don't mean to poke any fun at Australia on this, because they've done some of the hardest hitting and the most creative anti-tobacco campaigns in the world. They've been models for the world. In fact, New York State has used some of their ads as part of our campaigns. Okay, so were we set up for comments coming in?
Yep. Anybody can send it on the chat.
Okay. So let's get some chats. Let's go with the, did anyone find where the error or perhaps the mismessaging was? I did not like it. It said to make it smoke free, yet she was smoking in the house. Just because you smoke when the children aren't home, it's not the same as smoke free. Mm-hmm. Very nice. You're getting the third-hand smoke in the house. And still had cigarettes in the car. Yes, can we go back to that very last segment with the car? It's just before that. Let's back up just before that. Okay, here we go. See that? Someone got that. Okay, so what, so even subliminally, the messaging that it's giving is that it's okay to have your cigarettes in the car, but put them away when the kids come in the car. Mm-hmm. Okay, and again, that may be reinforcing the parents who are smoking when the kids aren't in the car, but will never smoke when the kids are there, and they think they're doing the right thing, but in fact, they're still exposing their kids to third-hand smoke. And about kind of modeling the smoking in the house, that was actually one that I hadn't caught. So that's actually very good that you're kind of showing smoking in the house, which may be giving the wrong message. Okay, so let's move on.
One more comment.
Okay, one more comment. Message was unclear how to help a participant quit smoking. Right, what do you do if you're concerned about this? You always want to tag on something about how do you make it better if you're raising awareness and raising concerns. Beautiful. Okay. Okay, so let's talk about some of the alternate tobacco products, hookah, e-cigarettes, and smokeless tobacco. And so hookah it has the potential for becoming a global epidemic. It was confined to countries in the Middle East some years ago, and then with social media and the inclusion of all sorts of flavorings and kind of the view of it as what a great marketing opportunity to sell a lot of stuff around the world. It's really expanded outward to the US and to other countries. And with the flavorings, it's really targeted especially to teens and to young adults, women in their key childbearing years, which is a problem. And there's a misperception that the hookah smoke is less dangerous than regular tobacco smoke because it's filtered through the water, that the stuff gets filtered out in the water, so what you're getting isn't as bad for you. That is an absolute myth, that in fact, very little is filtered out by the water, only the very largest particles. And the primary purpose that the water serves is that it cools down the smoke enough so that you can inhale it more deeply into your lungs, which is something you really don't want to do with such toxic smoke. And so you're getting exactly what you're getting from other kinds of tobacco smoke for the most part. You're inhaling it more deeply into your lungs, and you're also getting exposure to the toxicants emitted by the burning charcoal on top of the hookah device at the bowl head at the very top, where you put this piece of charcoal and put a piece of foil over it along with whatever flavorings they are, heat it up, and then you smoke it through. And if you look at the very bottom of this slide, a typical 1 hour long hookah smoking session involves inhaling 100 to 200 times the volume of smoke inhaled from a single cigarette, which leads to a net effect on having blood nicotine levels the same as if you had smoked 10 cigarettes during that 1 hour hookah session. So you're getting a lot more exposure, you're getting a greater volume of smoke exposure that's inhaled now more deeply into your lungs because the water has cooled off the tobacco smoke. And if we kind of go around the clock here from the left to the right, the air quality in hookah cafes ranges from unhealthy to hazardous according to US EPA standards. People have gone in with air monitors and looked at what does the air look like in these hookah cafes. What about secondhand smoke among hookah users? A non-hookah user who is exposed in a hookah cafe has the carbon monoxide levels of a smoker. It's as if they had been smoking while they were sitting there during that 1 hour hookah session. The risks, as we said, are the same diseases we have from smoking, plus the exposure to the toxicants emitted from the burning charcoal or the heated charcoal. And also you have the risks of herpes if you're sharing the same tip. Even if you don't share the same tip, you're getting stuff. You're getting viruses that can be transmitted, bacteria that can build up inside of the hookah hose, inside of the whole hookah device if it's not properly clean, and it's being passed around from person to person. Is hookah safer? No. And there's even more recently evidence of, we know there's secondhand hookah smoke exposure. There's evidence now of thirdhand hookah smoke exposure, which isn't surprising. There's smoke, it goes somewhere when it disappears. But there was a study done in homes of hookah smokers who did not use hookah in the house. They would just use it outside of the house on the patio. But in fact, it had gone into the homes and it stayed in the homes and became thirdhand hookah smoke, so that the kids in the homes of the hookah users had higher blood levels of nicotine, NNK, which is a tobacco-specific nitrosamine, which is carcinogenic, it causes cancer, and acrolein, which is a significant lung irritant, even when the hookah smoking is done outside. It filters in and it stays there. And remember, we don't know how to get rid of it. Okay, what about e-cigarettes? Well, there are over 400 brands and 7,000 different flavors. Not a single one is currently regulated. It's still sitting with the FDA. I sit on the FDA Scientific Advisory Council, grappling with it. These things take a while to do, but currently not a single e-cigarette is regulated. That means it could be anything. That an e-cigarette is not an e-cigarette, is not an e-cigarette. Do you want your people to be using something that's not regulated? You know, what other kind of products are out there that people are inhaling into their lungs, thinking that it's just water vapor and that it's safe, that's not regulated? And what do we know that's in these cigarettes? Well, we know it contains a lot of toxicants, nicotine, volatile organic compounds, things like formaldehyde, those tobacco-specific nitrosamines, heavy metals, propylene glycol, which is a lung irritant, may predispose people to asthma. If they have asthma, it can worsen the asthma. Ultrafine particles that are inhaled very deeply into the lungs and can transport other things there. We know that e-cigarettes generate secondhand vapor, and we know that they also generate thirdhand vapor, same as cigarette smoke. And again, you don't know how to get rid of these kinds of things, and they can explode. So there's a huge controversy now on e-cigarette use. The question is, for someone who's using a cigarette, are they safer if they switch to using an e-cigarette instead of a combustible cigarette? It's sort of clinically a large controversy. I will say my bias, based on my read of the literature, and I say this as a scientist, is that most anything is less harmful than a combustible cigarette. Russian roulette is less harmful than a combustible cigarette. Combustible cigarettes, don't quote me on that, but combustible, don't tell your clients that, because we don't want them, but we certainly wouldn't clinically advise people to play Russian roulette. But you have a 1 in 6 chance of dying from Russian roulette. You have a 1 in 2 chance of dying, at least on the first try. You have a 1 in 2 chance of dying from a combustible cigarette. Just because it's less harmful doesn't mean that it's a good idea for people to use these things instead of quitting entirely. And the controversy is less so in pregnancy. Pregnancy is such a vulnerable time that it is not advised to recommend e-cigarette use among pregnant smokers. None of the guidelines, none of the national guidelines that I've seen has been anything other than say, during pregnancy, women should not be using, they should not be exposed to e-cigarettes because there's so many things in them that we're just discovering. There are things that are toxic in them that we know about. There are things that we don't even know to look for yet that we haven't studied. No e-cigarette use during pregnancy. It is not just water vapor. This is what's in. This is just a small list of what's in e-cigarettes. And sometimes they explode. There are specific risks in pregnancy. Nicotine itself is a potential teratogen, which means it can cause malformations in the fetus, in the child. It's associated with fetal growth restrictions, so the low birth weight babies, SIDS, adverse effects on fetal lung and brain development. The nicotine levels now of e-cigarettes are pretty comparable to that of regular cigarettes, and the nicotine refill bottles pose particular risks of acute toxicity or death. So we have the child-safe labeling now. They're child-safe bottles in New York State, but at some point the bottle has to be opened to refill the cigarette, and when it's opened, it can spill, it can get absorbed, it can fall on the carpet, the kids can crawl around and then get it, or the pregnant woman can step on it and it can be absorbed dermally. So there's specific risks to pregnancy to use of e-cigarettes. And what about flavorings? What about if someone says, well, I don't use any nicotine in my e-cigarettes, I just go for the flavorings. Well, the flavorings in e-cigarette solution also have negative health effects. So we've had studies that have shown that they're toxic to human embryonic stem cells. This isn't a good thing for the developing fetus, and also to mouse newborn cells. And the literature at least suggests that this poses specific risks for fetuses and newborns from the flavorings themselves, in addition to the risks that may be posed by nicotine, which can result in embryonic loss or in developmental defects in pregnancy. Okay, what about smokeless tobacco? Is that safe? Smokeless tobacco is not safe at all, and it's certainly not safe during pregnancy. Again, this is just a partial list. It increases the risk of premature delivery. It increases the risk of stillbirth. Same nicotine that will affect the fetus's brain development, low birth weight babies, increased risk of ADHD, increased risk of behavior problems, the same kinds of things that we see with other tobacco products. Okay, so let's talk a little bit about best practices. Well, so the best practices with all patients or clients: conduct a triple tobacco screen, which is screen for tobacco use, screen for smoke-free homes, screen for smoke-free vehicles. And when you screen, because of the diversity of tobacco products, and we've heard from you, and we've certainly seen it here, that people think that by switching to other tobacco products, they're going to be safe. It's important when you screen for tobacco use by the patient and family members that you include separate questions on hookah and e-cigarettes or vapes, so that if you say, do you use tobacco? They might say, well, no, we don't. And we've seen this here, but we'll say, well, how about e-cigarettes? And they'll say, oh yeah, I use those because that's just water vapor. Or what about hookah? They'll say, oh yeah, you know, I don't use tobacco, but oh, well, with my friends from time to time, and I'll use hookah. Okay, and the same thing for smoke and vape-free homes and smoke and vape-free vehicle rules. They might say, yes, they are vape-free, but they don't consider vaping to be tobacco use. So it's important to ask about all of these. Okay, so principles of tobacco dependence treatment, and many of you may have heard these before. Nicotine is addictive. It is one of the most highly addicting substances known. Tobacco dependence is a chronic condition. It may take a long time for people to finally be successful, and it needs continual management, which means every visit, every time, every communication, ideally from every health provider, especially during pregnancy and for women with children. Effective treatments exist, and every person who uses tobacco or who allows smoking in homes and cars should be offered treatment. We know that smokers want to quit, and this extends across tobacco users, with the possible exception now of e-cigarette users because of the perception that it's safe. But about 70% of tobacco users report that they want to quit. Most have made at least one quit attempt, and patients say when we poll them that advice from a healthcare provider is important to them, and this means you. And parents generally want to protect their children, so this is a window of opportunity. Okay, counseling is effective if it's delivered in a supportive, non-judgmental manner. It's usually well received. As little as 3 minutes can double quit attempts and successes, although you may have the opportunity to spend more time talking with them about it, and the more time you can spend, the more effective the intervention is likely to be. And some important components that have been identified are problem-solving skills. How do you deal with not smoking, or with asking someone in your family to keep the home smoke and the vehicle smoke-free? Support from clinicians like you, and social support. Okay? It's important to address tobacco use and policies even if the person is not ready to change. And we hear this a lot. We ran the Medicaid and uninsured services through the Quit Line for a number of years and talked to probably like 80,000 tobacco users. And we heard over and over again, you know, my doctor or my nurse or my healthcare provider said something to me about it, and I acted like it didn't matter at the time. But, you know, it stayed with me. And I couldn't help think about it. And finally, I decided it was time to do something about it. So even if people are acting like it's not getting through, you never know where you're going to say something and it's going to just percolate and finally people will stop. And offering help opens the door for further conversations with your clients. For those of you who attended the session on stages of change, you learned about the 5 stages of change: pre-contemplation, where people aren't even thinking about changing; contemplation, they're thinking about it, but yeah, not ready yet. I know I should do it, but not now. They're ready for action. They're getting ready to make the change. Their action, they're making the change, in this case, quitting smoking or implementing a smoke-free policy. And from there, they either go to maintenance or relapse. And if they relapse back to one of the earlier stages. And so your goal is really to help a pre-contemplator become a contemplator. If they're not thinking about it and you can actually get them to start thinking about it, that's a success. If they're a contemplator and now you're helping them to start to think about what kind of plans, they're starting to make plans, that's a success. So it's helpful sometimes to think about it incrementally in terms of at least getting them to the next stage. Okay, so how? What kind of tools are available for you? Well, the NCI put out the 5 A's, which has become the standard for intervention: ask, advise, assess, assist, arrange. Ask if you use tobacco, that triple screen about smoke-free homes and vehicles. Advise to quit, advise to implement 100% smoke-free policies. Assess their readiness, what stage they're in, their readiness to change. Assist them in making the change, and then arrange follow-up so that you can follow up with how they're doing at each of the visits. So how do you ask? Well, these are some tips that I've put on, and I'll just pop through these quickly because I want to make sure that we have time to go through the vignettes. But these are some helpful tips that people have identified from the field that the American Academy of Pediatrics has actually posted on their website. So not that you don't smoke or you don't use tobacco, do you? But leave it as an open-ended question. Sometimes it's helpful to get it up by depersonalizing before you get to what are you doing, to say, does anyone living in your home use tobacco? Who is it? Where do they smoke? Is that inside the house? And then get back to, how about you? What is your tobacco use like? We've talked about asking about other tobacco products and explore a little bit. So if someone says, no one smokes around your son, you may want to explore, like, what does that mean, that no one smokes around your son? Because maybe they are still smoking in the house, but not around the children. You have a rule about smoking, vaping in your home. How about in your car? And don't judge. Keep your body language open and your tone of voice to allow people to express whatever it is they're thinking about this. And how do you advise? So strongly advise them to quit and to implement 100% smoke-free policies in their homes. Look for teachable moments. I'm sure you all already know these, and I'll look forward to your comments on these. Personalize the health risks, and that's a good thing about pregnancy. Find what seems to make the most, what would resonate the most with that particular person. If you have someone who has a child who has asthma, you can really personalize the risk around the asthma for the child who they already have, and in terms of protecting the newborn, to giving them the best chance for not being born with asthma. And document your advice so you know what you've said, so when you come back another time, you'll know what kind of conversation you've had. Okay, so what do you say? So in terms of advising, I advise you to quit smoking. I advise you to go outside if you have to smoke and to stay away from the windows and the doors because the smoke can get in that way. Once it's in the house, it's going to stay there. Strong advice. Eliminating smoke exposure of your son is the most important thing you can do to protect his health. And personalized impact, as we said, on whatever you think will resonate most with that particular patient or client. And be specific. So having a smoke-free home means no smoking anywhere inside the home or car. And again, this is that issue of parents trying to protect their child, but not realizing that once it's there, it's going to stay. Okay. Assess their readiness to change. Are they just thinking about it? Are they contemplating? Are they actually taking some steps? What have you been thinking about quitting? What do you think it would take to make your home 100% smoke free? And if you get stuck, if you feel like someone is just, it's the yeah, but, whatever you say, it's yeah, but kind of a response. This can sometimes break that logjam. We use this a lot on the quit line, and we've used this a lot with our clients, and sometimes it surprises them. And I would actually start at the very bottom of the sheet by asking, what kinds of things are good about using tobacco? What does it do for you that's good, that's helpful? You know, what do you like about using tobacco? And people are often surprised by that. They'll say, well, no one ever asked me that before. And it probably is doing some good things for them, or else they wouldn't be using it. You know, maybe they're saying, well, it relaxes me, right? Okay, so whatever it is, it kind of gets them thinking that you're acknowledging that it's not, oh, you're so bad you're using tobacco, but that it actually is doing some things for them that in order to not use it, that's going to have to be dealt with. So you don't get to that quite yet, but you just ask them, what are some of the good things that it does for you? And then what are some of the things that you don't like about it? You kind of go from both sides of that, and then get to the quitting part. What would be some of the reasons for quitting? What would be some of the good things about quitting? And then what would be some of the challenging things about quitting? Okay, and that can kind of begin to break that logjam, to get a conversation going, so that you can then kind of go from there to say, well, you know, what do you think? You know, what's your thinking about this? And if you get the sense that they just don't want to talk about it anymore, that's enough for that one time. You say, well, you know, let's come back to this. You know, and maybe when you've thought about it a little, next time we can talk about it a little more. And it may get their thinking going. Or they may say, well, you know, maybe if we could deal with this one, it would make it a little easier. Is there one thing that we might be able to make a little easier for you that may help down the road? Okay. Assist, problems, solve coping strategies for quitting, strategies for implementing smoke-free homes and cars, for engaging other family members. And the issue of no matter where someone smokes in your house, it can hurt. How can you make these places 100% smoke-free? To look at what are some of the options, what are some of the possibilities, to brainstorm a little bit together. And let's go on, because we'll go to We'll address that when we get to the vignettes. And there's some resources I want to go through in assisting your clients. The New York State Smokers Quit Line, for those of you who may not be aware of the Quit Line, it is free, it's evidence-based. Make sure they dial 1-866-NY-QUITS. I'm not sure if it's the case, but the 800 number used to go to an adult hotline, which you don't want your clients necessarily calling if they're trying to quit smoking. But it's 1-866-NY-QUITS, and there's also an associated website. And for you to refer your patients to the New York State Smokers Quit Line, you can call the Quit Line. From time to time, they will make available free cards that they can send you to hand out. It depends on what their budget is like. Sometimes they have them, sometimes they don't. But it can't hurt to call them from time to time and ask, you know, kind of keep a stash of those with you if you can get them. Refer to Quit is good if you can actively tap your patients and clients in with the Quit Line. And you can do that by going to the nysmokefree.com website. And there are resources available for healthcare providers. And if you click on those, that can take you to where you can get a fax to quit form that you can print out, where you can directly send with the person's permission. You can link them in with the Quit Line, and that's what you see shown on your page. You can download that from the website. And there also is a place on that site where you can register for Refer to Quit, where you can do it online if you have a mobile device with you or when you get back to your office. And connecting them to, and also if you're sitting with them, they can call it while you're there. And if you can connect them directly while you're there, they're in fact more likely to use the Quit Line. Also, if they use online services on the New York State Quit Line, there's a link for them that will take them to a page that looks like this, where they can get free text messaging around quitting smoking to support them. There's an online forum, there's journal, there are other resources for them if they want to do the online quit program. And again, this is all free. What about pharmacotherapy? Well, we know about nicotine replacement therapy. There's the gum, the patch, the lozenges, the nicotine inhaler, which is FDA approved. This is the only inhaler that is FDA approved. It's pharmacologic grade nicotine. This is different from e-cigarettes and technology, and this is like the original vape pen in a pharmacologic form. And there's the nicotine nasal spray. There's Zyban, which was the first non-nicotine treatment for tobacco use, and there's Chantix. And Chantix is the only one that does not have data that suggests that there may be times where you'd want to use it during pregnancy. So in terms of the other products, counseling is the best choice. Quitting without medications during pregnancy is the best choice. But if your patients, clients are motivated and they just can't do it and might need a little extra help, it is worth their speaking with prescribers to see might the benefits of a trial of one of the nicotine replacement therapies or possibly Zyban, would that exceed the risks of exposure during pregnancy? And in fact, often these are used during pregnancy under the guidance of a prescriber, a healthcare provider. to help pregnant women quit and remain abstinent after pregnancy. Okay, follow-up visits. It's important to follow up at all visits and to check on their progress to see how they're doing. And you'll see there are a few examples here. I'll just let you read through those. Okay. And so let's go to our case scenarios. And this will be our first vignette. And this is something that might happen, let's say this is before you see your client. You're going to see your client postpartum, and this is what may have transpired when she was in the hospital post-delivery. Okay, so let's get some comments coming in. We're going to set it up for comments now. Okay, so you can go ahead and send in your comments. What kinds of things were helpful, were good about that? I want to point out that this was done within 3 minutes. This was the standard brief healthcare provider intervention. So what kinds of things, from your perspective, do you think were good? And are there some kinds of things that you would have, since you'll be seeing this person next, say, are there some kinds of things that you think would have been helpful for the physician to say that she did not? And while you're typing in your responses, someone had asked, could you get the fax, I think it was the fax to quit form that you're looking for sent to you, and we'll send that out along with the slides. Within, what, a couple of days we can get that out?
Yeah, the slides were sent this morning, but I'll resend them when I send out the evaluation form. Okay, so you want
the motivation form. Okay, sorry, yeah, glad to do that.
Yep, I will send all the slides this afternoon, or I'm sorry, all of the forms this afternoon, if possible, along with the evaluation for the webinar.
Okay, so let's see, what kinds of things would be helpful? Okay, provider sat down and talked to the client eye to eye, was more engaging than standing and talking down. Excellent point. Congratulated, celebrated her efforts. Nicely gave information for the partner. Could have gone further in detail about the effects of secondhand smoke. Right. Honest about how harmful, even on their clothing, can be harmful to the baby. Yeah. Really planting some good seeds that you can follow up on. Okay. Now when you see the mom, how would you, okay, here we go. Should have asked for the patient's undivided attention first. Yeah. Right. The patient was busy on her phone. Okay. Was not very convincing, very assuming. Okay. So you were a little less impressed, I think, by the doctor's manner in doing this. The paper could be discarded, but the patient was told she could bring that information to the client. Oh, yeah. So really to be able to do that handoff, if I'm understanding this correctly, even maybe to link with you, if they knew that you would be seeing her afterwards, would that be an opportunity for handoff to say, let me give you these materials, someone will be seeing you, share these, these are some things that you can discuss in more detail. Mm-hmm. Would that be helpful to you? Okay, so let's talk about so when you see that, how would you start? This is what she knows so far, what she's heard in the hospital. Maybe her OB said something, maybe not. Hopefully the OB said something during the pregnancy. But where would you start? What would you work on with her? Nice. The doctor could have helped her connect right there on her smartphone in case she had the urge to smoke again, rather than just using the pamphlet. Perfect, right? Yeah, active, and also using what she has, which is she's already using her smartphone. And also the fact that she may have been texting on her smartphone to say, and by the way, online, there's this text to quit feature. Let's take a look at it now. And why don't you sign up for it? Right? And also calling the quit line just to see what it's about while she's in the hospital. And in fact, patients who get connected in the hospital are more likely to follow up. Beautiful. Love it. Okay, let's keep it going. What else? What are you going to do when you see her? Where would you start tackling the issue with her? Open-ended questions to see what she already knows. You're not telling her something she's already aware of. Beautiful. Are there particular side effects that you're hearing a lot from your clients or patients? Things that they're pretty much aware of? So sudden infant death syndrome, and that's an important one. Great. Yeah. Low birth weight. Are they seeing that as a good thing or a bad thing? The low birth weight. And by the way, for any of you, if you can't, bad but not ready to change. Okay, so not enough of a motivator, right? Okay. And if anyone can't see these comments, please let us know so that we can try to help you fix that. Everyone can see. Okay, so you're talking to the patient, the side effects. What about the partner who's, so we've got the patient who is worried about relapsing, and a really good suggestion to link her in. So if the baby is born healthy, or their other babies were born healthy, they may continue using tobacco. Okay, so let's get some input from the group. What kinds of things have you said in cases like that seem to have resonated? I know from our side, sometimes people will share stories, specific stories of kids they know, where, baby number 1, maybe even baby number 2 was born and was perfectly fine, and then baby number 3 was born with asthma or some sort of a birth defect that we know is a known risk of tobacco use, and just how bad the parents felt, and they wish they had quit. That they hadn't waited and hoped for the best, that it's an opportunity to really prevent anything bad from happening. But sometimes those stories, someone I know, someone I talk to, without obviously divulging any confidences or identifying the person, but those stories can sometimes be powerful. The doctor should have asked, do you need help speaking with the father? Yeah. So what kinds of things have you done in situations, or what do you think might work with your clients? Because it does sound like that was going to be an issue with the father not smoking in the house. What I gather from your comments, there's a lot of wisdom out there in your group. What have you found that has helped with the partners? And sometimes starting that might be like one of the first comments was to ask to say, are there some kinds of things that you've thought about that you think might work with a partner? What do you think might work? Because people are more likely to implement things if they've come up with them themselves, because it's not such a big leap. Show them the toxins that are in a cigarette, secondhand smoke, and thirdhand smoke. Yeah, sometimes that's and especially that secondhand and that thirdhand smoke. Remember, if families believe that thirdhand smoke is a problem, they're more likely to quit. Sometimes you get irritated if you keep bringing it up. Yeah, so how do you handle that? Because, what would you do like if someone was using heroin during pregnancy and they didn't want to hear about it when you were talking to them about it, or if they were doing something else damaging and they didn't want to talk to you about it? Have a conversation outside of the home regarding smoking. Okay, so like, you mean separate when the partner isn't there, or talk to the partner separately? So that they don't feel the pressure of kind of everyone sitting around staring at them. Nice ones. Okay, did not judge her and just make sure you kept following up. Yeah, understand the client is in which stage of change it is. Yeah, so sometimes there may be that mismatch when you're bringing it up, where you can kind of go back to an earlier stage. Maybe you say, I can see this is really a sticky issue for you. What about it makes it so tough? If it's her smoking or her tobacco use, maybe that question about what is good about it for you might break that log jam a little bit. Or if it's the problem with the, just being afraid to raise it with other family members, or a different location other than the home, too comfortable and sensitive. So are you thinking in terms of like talking to them, having a conversation in a different place? Yeah, other than the home. Okay, yeah. That maybe if you talk to them somewhere else, that it might be just enough of a distance. Okay, very nice. Let's get a couple more comments and then we'll move on to the next vignette. There's some overlap with these. Nice. Reduce smoking and applauded the small leap. Yeah. Very nice. Right. Even small steps are going in the right direction. Beautiful. Okay, let's go to another scenario and get some input. And these are areas where people have listed. So these are things that people sent in. Oh, can a pregnant woman use anything to quit smoking? Yeah, so, we talked about the medications, and sometimes medications are advised during pregnancy, and that has to be done with a prescriber, but there are studies on nicotine replacement. It is less nicotine than it would be from a cigarette, so the overall exposure is less. But then there are other little tricks, like there are some studies that have shown if she's using a combustible tobacco product, that some sort of especially like a cinnamon candy or like a sip of lemon juice, something that burns the back of the throat, can actually reduce the cravings. There's something about, so a part of that experience of smoking is that burning sensation that you get on the back of your throat when you're smoking, and you probably get a conditioned response to that. And so there actually is a little research out of Duke that if you put something else that sort of burns the back of your throat, not in a harmful way, but that gives you that same sort of tingling sensation in the back of your throat, that can actually manage some of the cravings. So clinically, I can say we'll often recommend like, a little, just a little lemon juice or a little hard cinnamon candy to see if that can get you through the moment. And then it's the quit line and the website. Yeah, there's the online forum that they can go to, or the quit line is available 24/7. Anytime they need to talk to someone, they can call into the quit line. Okay, so here's our next vignette. I cut down on my smoking from a pack a day to 3 cigarettes a day. I'm substituting lots of candy for the cigarettes. And that's something that I'm sure a number of you have heard. So her doctor didn't suggest anything to her, which she found weird. So it may be another health provider, or it could be something that she could raise like with a quit coach, and her physician may not have been trained yet. We are, through these centers, we're trying to go to as many places as we can to put in place policies to get all providers trained, and I will give that feedback that we're still missing. Was this an OB, or was this a pediatrician, or her primary care? OB, right? Yeah, that's actually kind of our next frontier. Will be the OBs. So she may want to speak with her transfer to high-risk clinic. Okay, and if she has a primary care provider, she may want to talk to her primary care provider. At some point, she'll be able to talk to her pediatrician, but her pediatrician may not have been trained yet. Her primary care provider may be able to speak with her OB and kind of problem solve around that, because they may be more likely to have gotten some training. Okay, so why don't we post so we've got a couple of vignettes up here, and people have asked for some help with these. And if you can, let's get some comments going on what kinds of things have worked for you in these situations. And as you're thinking about your responses, I can say in terms of the substituting candies, one of the withdrawal symptoms from smoking, from nicotine, is a craving for sweets. So sometimes you can mitigate that by saying, that's a very normal response, and it shows that you're kind of going in the right direction if now you're starting to have a sweets craving. It means that your body is starting to recover from the nicotine. And there are multiple ways to fill that sweets craving. And so then it becomes, how else can we address that sweets craving in addition to candy? So part of it depends on how much candy she's eating. It sounds like she's eating a lot of candy. If you're sucking on a hard candy from time to time, you're probably going to be okay unless you have gestational diabetes. But if she's eating lots and lots of candy, this can be problematic. So there are other ways, like fruits, for example, or but even canned fruit or frozen fruit that might be more affordable. So to kind of come up with some nice things that she can use to satisfy that sweets craving, knowing that that's perfectly normal to have a sweets craving when you're quitting smoking. Okay, other thoughts for your colleagues about some of these vignettes? We've talked about vaping, so you have the list of actually that it's not just water vapor, that there's the belief that it's water vapor, but it's not just water vapor. And you still have the secondhand vape, and you have the third-hand vape that stays there. And let's see who else has dealt with some of these concerns, and what kinds of things have worked for you. We've talked about, I don't think the smoking hurts my baby, but has anyone found a particular thing that you've said with a client when they've had that attitude, or that belief that I don't really think this is as bad as they make it out to be, that has really resonated for them? And as you're thinking and hopefully typing in some responses, a couple of the things we found is that sometimes when our clients are saying, I don't think it's that bad, that they're really saying, I don't think there's anything I can do about it. That really it kind of comes back to that they're afraid that they're not going to be able to quit. So they kind of deny it. They're kind of in denial and say, I don't really think this is going to hurt my baby. So sometimes taking a step back to that conversation of, what is smoking doing for you can get that conversation moving. What's good about it, what's bad about it, what about quitting, what's bad about quitting. And also sometimes the stories of patients, clients you've seen where the baby has been affected, and then how the mother has felt afterwards. Some smoke pot. They say it helps with nausea and to relax. And we'll probably be seeing a lot more of that as marijuana becomes deregulated or decriminalized. So, obviously for now, it's not something that that would be recommended as being safe during pregnancy. And also smoking is a particularly toxic way to do it. So smoking anything brings toxicants into the body that then get passed on to the baby. Again, I welcome any responses that people have that have worked for you in that kind of a situation. But certainly what we do is we would deal with it like we would deal with smoking cigarettes or smoking tobacco, that it's anytime you're putting some sort of a toxicant in. And if nausea is a problem, then to problem solve, that I'm sure you've done, around other ways to deal with nausea that would be more healthful. There you go. Explain what goes in your body goes to your baby. Beautiful. A visual aid. Are there particular visual aids that you've used that have worked well? And as we're listening, as we're watching to see if we can get a visual aid coming up in the last few minutes of the webinar, I just want to open this up to any questions that you all might have to put to me and to the group to draw on the expertise we have here among all of you. A pamphlet that says, what goes in your body goes to your baby. If you can send us the source of that, is that something we can circulate to the group? Mm-hmm. Okay, great. If you have it, okay, perfect. Thank you so much. Okay, and are there particular other questions that people might have for the group? Okay, every cigarette does you harm. Encourage not smoking full cigarettes at a time, just having a couple of puffs and then putting it out. That's kind of an interesting suggestion, just smoking a couple of puffs and then putting it out. The problem is that if they're doing it, then they may do more cigarettes, or they're still getting, so it's total exposure that's the issue. But if that's a strategy on the way to quitting, to just kind of try to change up how they're smoking a little bit, they're not willing to quit yet, but they're willing to try some different things, then, maybe it's a strategy that's worth trying to get them, again, moving forward towards quitting, to just try doing it differently. Sometimes you can break it by smoking or using tobacco in different places. So like if you do it every morning with a cup of coffee or a cup of tea, not doing it then, just somehow breaking up the usual habits, the usual patterns. But again, if it's on the way towards quitting, then that's a good thing. Okay, other questions people have? Okay, well, we will put together the slide set for you again to send out, the Motivating Change worksheet, and when we get the pamphlet, what goes in your body goes to your baby, and we will send that back around to you. And if you look back, again, the second slide you'll see will be the link to the CDC resource, the training page, where if you want more information and to look into more resources, that's available to you for free. And, okay, thank you, from Childbirth Graphics. Okay, great. And also the Quit Line and the Quit site are available for you too. So, if you're waiting somewhere and you have your laptop or your tablet with you, or you have a few minutes to just kind of look around there and see what resources there are. And that might be something that you can pull up when you're dealing with your clients. Well, Thank you, everyone, for the opportunity to present to you and to talk about something about which I will say I am passionate and have really dedicated my career to. I applaud everything that you are doing in the field. You really are the frontline workers who are making a difference, and what you're doing is saving lives. At the end of the presentation, when it comes to UC, I've added just a few more videos that I thought were particularly good videos in terms of messaging from some may be used in New York State, some are from other sites, but if you do use visuals with your clients, it might be useful to you. You are making a difference. It takes time. Count your successes. You're building a warehouse of stories, and share those successes, because you never know what something that you said to your client that made a difference might be able to help someone else.
Thank you, everyone, for joining us, and look out for the next webinar.